Hi, good afternoon, everybody. Thank you for coming. Thank you for taking time out of your lunch to come and attend this public awareness talk. Today, for those of you that may or may not know, September the 19th is Aortic Dissection Awareness Day. My name's Andrew Chung. I'm a vascular, endovascular, and aortic surgeon at the Asian Aortic and Vascular Center here in Singapore. And we are, for the first time, trying to stream this public awareness talk live and have an audience as well. So we've had a few teething problems this morning, so bear with us, but I think everything's working now. I want to thank Medtronic and the technical team, and as well as the ops team at the AAVC for helping us facilitate this. I hope it will be of interest. I think most importantly, we are going to be recording it, and then we're going to try and upload it to a few different places as well. So for those of you who have missed it, you can watch it later. So September the 19th, being Aortic Dissection Awareness Day, is not something that people are very familiar with. And in addition to that, people aren't familiar with the idea of an aortic dissection at all, in fact. And so the idea behind events like this, talks like this, and naming days after a disease is really to heighten public awareness, improve people's perception of the disease process, and hopefully, ultimately, get better outcomes for patients who do suffer from aortic dissection. I found this cute slide. I thought it was important to share it with you all today. And if you need to find me and my details, this is me. I happen to be on Facebook, Instagram, Twitter as well. And that's my handle. Now, there have been quite a few high-profile people that have died from aortic dissections. This is Richard Holbrooke. He was President Obama's special envoy to Afghanistan. And he was quite famously saying that we've got to stop this war. And he died having had delayed surgery for an aortic dissection. Probably slightly more famously is this chap, John Ritter, who again died from an aortic dissection. But very sadly, in John Ritter's case, the reason why he died and the reason why many people die is that the diagnosis was exceptionally delayed. And that's part of the problem with aortic dissection. And I'll do my best to explain it as best I can in non-expert terms so that everyone can try and understand what's going on. But as a result of John Ritter's death, he formed the John Ritter Foundation, and they now are a big patient advocacy group in the United States. And they're there to promote knowledge of aortic aneurysms and dissections through research and education. So some good has come out of his death. And I'll be talking a little bit more about what he calls Ritter's rules later on. So this has come directly from their website. This is from the John Ritter Foundation. And this is really important. Aortic dissections are preventable, and I'll get on to talking about what they are in a second, but I just want to give you some data on them, all right? Early detection and early treatment can prevent premature deaths. 20,000 people in the United States suffer an aortic dissection every year, and up to 50%, that's a huge number, 50% of people with an aortic dissection will die, all right? So that's something that's really important to bear in mind. That's terrible, terrible statistic for almost any disease process, 50%. But 80% of people can survive with prompt diagnosis and treatment. So that's huge. If you have an aortic dissection, your chances of survival, if you are diagnosed and treated correctly, promptly, and accurately, are up to 80%. So I just want you to bear that in mind as we talk about this a little bit further. And like I said, John Ritter now, for the last 20 years, has been committed to raising awareness and hopefully changing outcomes. And this small public talk is my way of trying to help with that process as well. And it happens to be a specialist interest of mine. So that's why I'm here today. So going back to the absolute basics, what is the aorta? All right. It's quite simply the largest blood vessel in the body. All right. It starts at the heart. It curls round. It basically runs along the spine, and then it goes across the chest into the tummy, and then it goes into the legs. And basically, the aorta is the blood vessel that communicates all the blood around the body. So the 5 liters of blood that's going around every minute, the aorta is the main pipe that drives that. And every single organ is derived from a branch of the aorta. It is exceptionally important, obviously. Now, heart surgeons will tell you that the heart's the most important. And obviously, aortic surgeons will tell you that the aorta is the most important. I like the aorta. So I'm going to tell you that the aorta is the most important blood vessel in the body. So what is an aortic dissection, right? What is it? What are we talking about? And this diagram is probably the easiest and best way to describe it. It is a medical and surgical emergency, first and foremost. And basically what happens is that a tear forms in the lining of the aortic wall, and then it separates those layers, and it sort of can be prone to bursting or rupturing. And so what are the stages of an aortic dissection? Well, quite simply, if you've got normal blood vessels, you've got nothing to worry about. But each blood vessel, and this is every blood vessel in the body, has 3 layers. It's got the outer layer, the adventitia, the middle layer called the media, and the inner layer called the intima. And if your blood vessels are normal, nothing to worry about. But what we think happens is that you get a small little hole in the inside layer, and then blood tracks through, and it stretches then the middle layer and the outer layer. And that can lead to bursting. This is another diagram showing basically the same thing. And there are a number of different ways that you can have this happen. You can have a little hole, you can have a little rupture in the blood vessel, or you can have a plaque that's formed inside the blood vessel and that breaks. But essentially, it causes the same thing. You have abnormal blood flow in the layers of the blood vessel, and that causes things to stretch and splits the inner lining of the blood vessel. That's probably the best way to describe it. So this is really important. So what can happen? And this goes back to what the aorta does. You'll remember I just told you that the aorta supplies the whole body. And as a result of that, a dissection can cause problems throughout the whole body, depending on which blood vessel is affected. So in the most serious instances, it can split and go towards the artery supplying the heart, causing a massive heart attack, and that can cause sudden death. It can split the blood vessels supplying the brain, and therefore it can cause a stroke, and that can almost certainly sometimes be fatal. It can split the blood vessels that are supplying the arm, and so you can get a sudden painful cold hand or both hands. It can affect the arteries supplying the guts, the stomach, the kidneys, the liver, and therefore it can cause severe abdominal pain. And it can also split all the way down to the legs and interrupt the blood supply to your legs, causing painful ice cold legs. And so this is why aortic dissection is so hard to diagnose, or why people struggle so much, because it can present like anything. People with aortic dissections, a lot of people think they're having a heart attack. People have a stroke, but actually it's because of a dissection. And so they get given an incorrect treatment early. People present with abdominal pain, severe abdominal pain. People think it could be a ruptured appendix or a perforated bowel, but actually it's a dissection. And so aortic dissections really are called the great mimicker. They can be many, many, many different things. And that is why it's so hard to diagnose. How serious is an aortic dissection? I told you earlier that about 50% of people that present with one will die from it. It's really serious. 20% of people suffer instant rupture and death. All right, that's 20%. So if you dissect, you've got a 1 in 5 chance of just dying on the spot. However, if you make it to hospital or a medical facility which has aortic expertise within an hour or two, your chances of survival are about 75 to 80% as per the Ritter Foundation and 75% as per this journal article. That's amazing. But as time goes on and the diagnosis becomes less unclear, your survival rate drops quite dramatically. So at 2 to 6 hours, your survival rates drop to 65%. At 7 to 12 hours, 60%. And if you have a dissection and you don't get urgent, correct treatment and diagnosis, after 24 hours, your chances of dying are 50%. And that was the statistic we referenced earlier. So, and what are the factors that delay the diagnosis? You need a definitive CT scan. And the problem is, like I said, there are a lot of clinician factors: incorrect diagnosis, waiting for blood tests, referred to the wrong specialty, incorrect management. And it's not necessarily anybody's fault. As I already said, it's just that aortic dissection is the great mimicker. It can present as anything. So it's incumbent upon me as a vascular and aortic surgeon and somebody involved in public health awareness to try and train my emergency surgery colleagues and the public and all my other colleagues about when an aortic dissection can present and how. So one of the big public health and awareness campaigns that's come out of the US and the UK is this thing called Think Aorta. And it's really, really simple. Have you got unexplained severe pain? And if you do, get a CT scan. In the old days, CT scans were exceptionally expensive, very cumbersome, and they were very difficult to get a hold of. They are now the gold standard in hospitals all over the world, especially in Singapore. Every single one of our restructured hospitals probably has at least one or two, and it's the same for those in private practice. So unexplained severe pain, think aorta. Now, there's a number of symptoms down there, and I won't go through them all, but it is the number one symptom in the neck, in the back, in the chest, or the abdomen. And every single patient who's ever presented with a dissection, when you ask them, can you remember a time when you had pain? They will say, yes, I was absolutely fine. And then suddenly, and this is the most common thing, I had this tearing pain in my back or this tearing pain in my chest. And it literally is tearing because, as I showed you, that's what's happening to the aorta. It is being stripped on the inside, and your blood vessels literally been torn from the inside out. And they always complain about that. Now, there are lots of risk factors. There's history. There's a bicuspid aortic valve. It could be genetic. High blood pressure is a big one. But those are the things that we try and focus on. So CT scan for a definitive diagnosis, and that really is the gold standard. There is no other way of being able to really tell. Ultrasound, echo, they're all quite useful and helpful, but it is a CT scan that you need. So Ritter's rules, again, lots and lots and lots and lots of things, mainly for medical professionals. But after John Ritter suffered his death and his family set up the foundation, their primary goal was to try and set up some rules. And again, just to repeat it, it's a medical emergency, and the death rate increases 1% per hour for every hour the diagnosis and surgical repair are delayed. That's huge. And again, severe pain is the number one symptom. And they say seek immediate emergency medical care for sudden onset of severe pain in the chest, stomach, back, or neck. And again, the pain is likely to be sharp, tearing, ripping, moving, or so unlike any pain that you have had before that you feel something is very wrong. So that's all you need to know. If you ever suffer from that, you just need to tell the doctor that you first see something is very wrong. This is the most severe pain I've ever had, and just describe it as that. And that should ring alarm bells for somebody looking after you, treating you, and that should prompt a CT scan, as well as a number of other things, don't get me wrong, to exclude the potential of an aortic dissection. So this is just a little bit more information for those of you that are curious and would like to know about it. Type A is one that starts in the ascending aorta, type B in the descending aorta, and that's really about where it is on the curve. It's very technical. You don't need to know, but it's important for medical professionals to know because the treatment is slightly different. Type A invariably revolves open surgery that requires your chest to be opened. Type B dissections, which is the things that I specialize in, and those around the aortic arch, those can be treated with a stent. So how do we treat aortic dissection? Well, this is literally it. There is a hole there. There's normally an entry hole. There's normally an exit hole. And we just need to cover the entry tear most of the time. Again, amongst vascular surgeons, we can debate endlessly about the benefits of closing the distal tear, etc. But for all intents and purposes, we need to close the entry hole. And what you see here is you see an entry hole, you see the aorta, you see the aorta being stripped away, and you see a stent put in, and that has closed the entry hole. So how do we do it? Well, this is a stent being put in, and it's all minimally invasive keyhole surgery. And this is a device that goes into the patient's blood vessel from the leg, and we unscrew it and unsheath it, and we reline the aorta with a new blood vessel, basically. It's made out of very clever polyester type material. The stent is made of something called nitinol, which is a nickel of alloy and nickel, and it's very flexible but strong, and it opens up, and that is how you seal the aneurysm or the dissection from the inside. Very, very quickly, because today is Aortic Dissection Awareness Day, but we would be remiss to not talk about aortic aneurysms. When you have a dissection, and when the aortic wall has been torn, it gets weaker. And when it gets weaker, it can blow up like a balloon. And that is exactly what an aortic aneurysm is. It is when the aorta has blown up like a balloon. So what we have here is we have a normal one on one side, and we have the abdominal aortic aneurysm on the other side. Aneurysm balloon, abdominal in the abdomen. How do we repair it? Same principle, really. A is the open surgical repair, where we make a cut into the tummy and we sew in a graft. B is the stent graft option, very similar to what I showed you just now. And that, again, is minimally invasive keyhole surgery using a device that goes into the blood vessel. This is the traditional open repair again, just another example of what we do. Open the whole thing up, stitch in a graft, and then cover it over. And this is a stent graft in the infrarenal abdominal aorta. And it's exactly the same principle. It goes in, there's hooks at the top to fix it in place. We unscrew the device and it opens up. And through the radial force, it holds itself in place. And then we pull it back down, hold it in position, and then we unscrew it all the way out. This one's quite a little bit different in that it's got a trouser leg, and that trouser leg is basically because we have two legs. So we have one leg for one side, one leg for the other side. And that is one leg completed, and then we come from the other side and we just complete the stent graft placement. So last slide. Unexplained severe pain. Think aorta. Aortic dissection is an emergency that is often fatal when it is missed. You need a CT scan for a definitive diagnosis. There are vascular surgeons all over the world. There's plenty here in Singapore. There's about 40 of us. We're all over in both the restructured and in private practice. Keep calm and call Vascular. We can help. Thank you very much. If there are any questions, I'll take them now, or else we can end the session. Okay, that's it. Thank you very much. Oh, sorry. Oh. I've got a question being asked about how long does the stent last? Well, the stent will last hopefully for the remainder of the patient's natural life. Is the long answer, or the short answer rather. The slightly longer answer is that at about 20 years, the longevity of the stent gets called into question, not because of the stent itself, but because of the aorta around the stent. It's quite hard to describe, but the aorta itself is diseased. You need to look at it as a diseased organ, and over a period of time, it will often degenerate further. And so that if you need a reintervention, it's not because the stent has failed per se, it's because the aorta around the stent has failed. In terms of how many stents you need, there's been a question about that. Well, it just depends really. It depends how severe the dissection is. It depends how extensive it is. Most of the time you need 1 or 2. For an aneurysm, you need a bare minimum of 3, often 5. But that's basically the kind of numbers that we're looking at. They're bigger devices than the heart stents that cardiologists use. Sorry, yep.
In the body. So why does it happen actually?
Yeah, no, so that's a good question. So there are a number of different factors. So first of all, there are genetic factors. Some people are just born with an aorta which is slightly more fragile and more prone to dissections. And we know that is true in Southeast Asia in particular. The incidence of dissections, particularly amongst an Oriental population, so in Japanese, mainland Chinese, people in ASEAN of Chinese heritage, it is more common. We don't know why, but that is one thing. It's genetic. It happens far less commonly in the United Kingdom and the US. Again, we don't know why. The flip side of that is that aortic aneurysms are more common in the US and in a Caucasian, an ethnically Caucasian white population. Abdominal aortic aneurysms and aneurysms in general are more common and less so here. So there's genetic factors. The other big one is blood pressure, uncontrolled blood pressure in particular. And you can understand why, right? If your blood pressure is abnormal and high and it's pumping all the time very hard and fast, it is much easier to get a dissection happening. And then you've got all the other cardiovascular risk factors: smoking, just getting older, being a man, unfortunately, predisposes you to a dissection, diabetes, high cholesterol, etc. So yeah, those are the general reasons as to why it happens.
Question, like, what exactly kind of like warrants like a root implant? Because I know of someone who recently had this, and then they had to go through that whole root implant, a very invasive procedure.
Yep. So the problem is really, as I hopefully was able to demonstrate, it's not so much the aorta itself, oftentimes that's the problem, but it's the blood flow being affected from the branches. And so if you get a dissection that goes back towards the heart and it affects the coronary arteries, they normally present with both a dissection but also a severe heart attack. And that's because the blood vessels to the coronary muscle itself have been affected. That's number one. Number two, it also affects the valve. So the valve is sitting there. But if you can imagine the valve is sitting in the aorta and then suddenly it strips down across it, that's when it becomes a problem. And so sometimes they need the whole thing replaced, their coronary arteries, their aortic root, and the aortic valve. That's called a Bentall procedure, and it does happen not uncommonly for those who have a dissection. Yes.
Yeah, thank you for the talk. Yeah, so I was just wondering, with such a high mortality rate, would regular screening help, or should it be something that we ask for when we, do our yearly exams?
Yeah, no, excellent question. I think annual screening and surveillance, because this is an emergency, it happens all of a sudden. So unfortunately, screening is not necessarily going to pick this up. What screening will pick up, and I think this is important, particularly for those at risk, that would be males over 55, coming for a one-time ultrasound scan to look for an abdominal aortic aneurysm. That should be a part of health screening. It's still currently not. It should be. There are financial implications of national screening programs. In the US, in the UK, they tried it, and they have to justify the expense of it. And that becomes a slightly difficult issue. But if you have taken charge of your own health and you want to just do a one-time screen, I would highly recommend people do that, particularly those at risk, because it's such a simple and non-invasive thing to do, and then But unfortunately, dissections don't get picked up like that because you just present as an emergency. They've got another question here. Can we just take medicine? You can. There are people that do just take medication, but again, it depends what type of dissection you have, and that still needs to be done under expert supervision and guidance. So I have a number of patients, I don't stent everybody, I have a number of patients who we control with blood pressure tablets, very aggressive blood pressure medication and surveillance, but you still need to, number one, make the diagnosis first, number two, get to the right specialist so they can make those assessments and judgments. In terms of prevention, sometimes it's hard. It's sometimes impossible to prevent, but making sure that your blood pressure is well under control is probably the strongest thing I could recommend. Every one of us can do that. You can just take a blood pressure monitor and see what it's looking like, and then go and speak to your general practitioner or your cardiologist. And lastly, I've got another question here. I've got a heart problem and need to take aspirin daily. Am I at a higher risk? All blood thinners will put you at a higher risk of having a problem with the dissection if it happens. It won't put you at higher risk, but it could make your dissection worse. And this is one of the big problems with the diagnostics, because when people present sometimes with a stroke, they think that they've got a blood clot in the brain, which, don't get me wrong, that is most of the time the right cause. They've been given very strong blood thinners, and that makes their dissection worse. And it can make the dissection extend further, and it can sometimes be fatal. So again, most of these things you shouldn't be trying to work out yourself. You should be doing it with your doctor, who has a specialist interest in the aorta, who understands what to do, and have a discussion about whether the risk is elevated or not. But in principle, taking a daily aspirin doesn't put you at higher risk.
Andrew, can I ask, beside high blood pressure, any other symptoms for aneurysm?
Pain is the other one. So pain, aneurysms sometimes present with pain. They sometimes present as a lump that you can feel. I often get referrals from people thinking they've got an aneurysm, or a GP thinking that they felt an aneurysm because they feel a pulsatile sort of swelling in their abdomen, a little bit of back pain that can be unexplained. Those are the kind of things that, worry us. The typical presentation that we always got warned about in medical school was a 65-year-old man presenting as if he's got a kidney stone. So he's writhing around, he's in pain, he's got pain in his back. Oh, it must be a kidney stone. You have to exclude it being an aortic problem. And again, put very simply, the reason why you get chest and back pain or you get back pain round here is because the aorta runs along the spine. So any problems that happen to the aorta, all the nerves in and around the spine and the back are right there. And that's when you sort of come up with back pain. It's not always obvious, but unexplained back pain or things like that, just go and see somebody. Could it be my aorta? It's a very simple question and it's a very simple test just to check. Okay, great. If there are no further questions, I'm going to say thank you very much again for everyone for coming, and I hope that was helpful. Thanks, everybody.